For today's session, I feel honored to invite our chairperson, Dr. Neha Gupta, ma'am. Ma'am is a senior consultant, DNB consultant, and HOD, Radiation Oncology Department at Apex Hospital, Varanasi. Ma'am is versed with advanced radiotherapy techniques such as IGRT, IMRT, VMAT, SRS, SRT. She has published many articles in national and international journals. Welcome, ma'am. Pleasure to have you for the today's session.
Thank you, Aditya. And it will warm greetings to all of you. And it gives me an immense pleasure to introduce favorite Dr. Vineeta Goel, ma'am. And she is a well-known figure. I hope she doesn't need any introduction to the radiation oncology fraternity. Still, I would like to say a few words about her. That she has an experience of more than 22 years. She did her DNB in 2001 from Tata Memorial Hospital, and she has been associated with Max Super Speciality Hospital for the past 2 years. Now she has moved to Fortis Hospital. Then she is a leading consultant there, and her professional memberships includes of ARI, Neuro-Oncology Society of India, Association of Gynecologists Oncologists of India, FHNO, ESTRO, and she has a special interest in breast, gynae-oncology, thoracic, pediatrics, head and neck neuro-oncology, and with special interest in IORT, 4D, RT, and DIBH. So she will be teaching us about the target volume delineation in breast cancer. Ma'am, over to you. Thank you.
So thank you, Dr. Neha. Thank you, the entire team of Apex Super Speciality Hospital for organizing this webinar and giving me this opportunity to speak. I will try to share what I know. I don't know whether I'm actually teaching or not, but I'll try to share what I have understood about breast contouring. And I hope my slides are now visible.
Yes, ma'am. There is.
So whenever I work in TPS along with my colleagues, I always feel that contouring or radiation planning is akin to surgery. It is like doing surgery. When we review our patients, it is like post-operative care. So what is important? Both are important. But if you do good surgery, only then you will be able to provide a good post-operative care. So if you do good contouring, planning, etc., then you will be able to take care of your patients while they are on follow-up or while they are going through the treatment. So let's understand that why do we need suddenly contouring for breast cancer also? We understand that radiation therapy to breast is associated with reduction in the local recurrences, and in long term, it translates into improved overall survival. But then there are concerns, the concerns about acute as well as late toxicity of radiation therapy, like lymphedema, pneumonitis, esophagitis, shoulder dysfunction in the early phase, and long term worry about cardiac disease and secondary cancers. So we need to optimize radiation therapy to obtain the maximum benefit and minimize the morbidity. And that is why we move to contouring, planning, and conformal techniques. So gradually, we've moved from 2D to 3D era. Earlier, we used to only talk about bony landmark based RT fields. Now, we do not talk so much about radiation fields. We rather talk about target volumes. Second. Okay. So before moving further, I would like to just take you through some of the salient points of normal anatomy of neck, breast, muscles, etc. So starting with sternocleidomastoid muscle, this is a superficial muscle in the neck. As you can see here, it originates from manubrium sterni and medial end of the clavicle, and it gets inserted on the mastoid process. Now, we must also know about scalene muscles. One second. So we must also know about scalene muscles. Scalene muscles forms the deep muscles of the neck. This is scalene muscle. So there are three scalene muscles, anterior, middle, and posterior. They originate from transverse process of C3 to C6 vertebra and get inserted on the first rib. Now we must also know about the pectoralis major muscle. Pectoralis major muscle is a one second. Sorry. So pectoralis major muscle is a thick fan-shaped muscle. It has two origins. One is from the clavicular head and the other is from the sternocostal head, from the anterior surface of sternum and superior six costal cartilages. It originates from here and gets inserted on the humerus. So pectoralis major muscle, as you can see here, it appears like a thick muscle, in the neck and appears as a flat muscle when we move to the chest region. Then we must also know about the levator scapulae muscle, which is a large flat muscle. It has multiple origins from scapula to third to fourth rib, D7 to D5 vertebra, and iliac crest, and ultimately inserts on the humerus. So this yellow one is the latissimus dorsi muscle. We also should have a brief idea about the vascular anatomy. So left common carotid artery and left subclavian artery arises from the arch of aorta, while on right side arch of aorta gives rise to brachiocephalic artery, which gives subclavian artery and then right common carotid artery. So this is the subclavian artery on the left side. This so both the subclavian arteries on the left side and the right side, after crossing the lateral border of the first rib, they actually become the axillary artery. So this is axillary artery, we know, has three parts, which is with respect to the pectoralis minor muscle, medial, posterior, and lateral to the pectoralis minor muscle. Similarly, for veins, the left and right brachiocephalic veins drain into superior vena cava, and they are further drained by left internal jugular vein, left external jugular vein, as well as left or right subclavian vein. And it is the left subclavian vein is continued as left axillary or right axillary vein. So axillary vein which drains into the subclavian vein. So now let's talk about the CTV. Defining postoperative CTV is very difficult. Why it is difficult is because essentially there is no gross tumor. You're not seeing any tumor. So how do you define your clinical target volume? It basically depends on your knowledge of anatomy, oncological understanding, and anticipated patterns of failure. So these are three concepts you use to define the postoperative CTV in the absence of any gross tumor. So I think basics are basics. First of all, we have to study a case in detail. A lot of people tend to think that breast contouring does not require much brains and it can be done at spinal level. I completely disagree with that. Every case of breast cancer, like other cancers, can be very different. We must start by reading the basic clinical findings like tumor size, location, relation to skin, relation to nipple areola complex. We must ourselves study the preoperative imaging like mammogram, MRI breast, CT, PET CT, etc. to further get an clear idea about location and relation of the tumor with the normal structures. We must also try and read the surgical notes. We must have an understanding of what is the standard surgical concept, for example, for breast conservation surgery versus MRM, and we must also know what is done for our patient. We must also know if there is any reconstruction, oncoplasty, repositioning of nipple areola complex, etc., is done during surgery for our patient or not before starting contouring. Knowing intraoperative findings, especially about the clip placement, is also very important. Please always read histopathology report in detail. Don't only look at the tumor size and margins and or the number of positive lymph nodes and get easily satisfied. Read it in detail. Spend time, so that you'll be able to do a better radiation therapy for your patients. So this is a picture I have shown in my previous talks also. So this was a patient where, she had right-sided MRM. So we were doing her simulation. So I noticed that the patient had a very unusual kind of a MRM scar. These are wires which are placed along the MRM scar. So the scar usually for MRM is quite straight, But here the scar was going upward like this. So I asked my colleague, what is the reason? Do you know why the scar is like this? So he simply answered, Maybe it's some new surgeon who operated." While when I started contouring, I realized that the tumor was quite, high in the location. The tumor probably was located here, and that is why when the MRM scar is being planned, the surgeons try to encompass the tumor. So that is why the scar was coming like this, which means we have to make sure that this area should not get underdosed. So please, pay attention to every small detail. Only then you will be able to do good radiation therapy for your patient. A starting point for any surgery is good anesthesia. For a starting point for any good radiation planning for us as radiation oncologists is a good quality CT simulation. Make sure that you spend time in positioning the patient, supine, use an appropriate breast wedge. As Dr. Tabassum also mentioned last time in her presentation, we generally try to do simulation with both arms above the head so that, the symmetry of the arms, neck, etc. on both sides is maintained. IV contrast, at least we don't do generally, it is optional. We like to place wires around the intact breast or the affected breast, around the scar, opposite breast, provisional field borders. I'll come to that in detail also. In case it is chest wall radiation and you plan to put a bolus, it is a good idea to put bolus even at the time of simulation, and make sure that the bolus is adhering to the chest wall, quite snugly, and there should be minimum air gaps. If you're planning to do DIBH, it is a good idea to obtain both free breathing and breath holding scans with a slice thickness of 3 to 5 millimeter. When we do contouring for head and neck cancers, we often do not put a lot of wires, but for breast, we like to put wires. Why so? See, breast as a tissue has fat, stromal tissue, etc., and it gets very difficult to localize it only on the basis of CT imaging. So there are a number of studies which have reported that the inter-observer variation in the CTV delineation decreases significantly if the wires are placed around the palpable breast tissue, and in addition to those wires around the breast tissue, we can look at the anatomical borders like sternum, clavicle, etc., in addition to the wires, so that the inter-observer variability reduces and there is consistency in CTV delineation. So I think there is a merit in putting the wires around the breast, and we must do so. When it comes to contouring guidelines, there are plethora of guidelines which are available. These guidelines have evolved, by in last almost 15 years. So I will gradually take you through all these guidelines and try to give you some consensus on what I follow and what maybe you can also consider following in your practice. So let's start by talking about the BCS or breast conservation guidelines. Before coming to the guidelines, I also want to emphasize that guidelines only serve as a template or a base on which the CTV can be adapted. We actually need guidelines as well as individualization according to the patient's anatomy, tumor location, histopathology report, etc. We have to remember that all these guidelines are applicable only for supine position and they are not meant for treatment in prone position. RTOG guideline, which was the first to come in 2009, is available for both early breast cancer as well as locally advanced breast cancer, while Eastro and Danish guidelines are applicable only for early breast cancer patients. So let's talk about post BCS CTV for an intact breast. Here the CTV of the breast actually is the total glandular breast tissue. And as discussed earlier also, we must palpate the breast tissue while we are doing simulation and place radio big markers around breast. We have to remember these markers may not always be correct because sometimes the breast can be very diffuse, or sometimes the lateral border is not very well defined, or the medial border is not very well defined. So whatever one can feel, put wires, but then when you're doing contouring, correlate the position of the wires with respect to the anatomical landmarks also. We have to also remember that CTV primary of the breast should also include the primary tumor bed with relevant margins. What I mean to say by this statement is, suppose there is a tumor which was there in the retroareolar or the central quadrant of the breast. Then obviously your CTV phase 1 of the whole breast will include it, adequately. But suppose there is a tumor which is placed in the upper outer quadrant, and if you do not make sure to give adequate margin to the primary tumor bed in the phase 1 CTV, sometimes you might, missing a part of the tumor bed there. So if it is very eccentrically located medially or laterally, make sure that your CTV primary breast is including the tumor bed with adequate margins. So now let's come to margins one by one. So the cranial margin. I think for cranial margins, all guidelines have a consensus. The consensus is that ESTRO, RTOG, Danish, all guidelines say that the uppermost level of the palpable or visible breast tissue, maximally up to the inferior edge of the sternoclavicular joint. So there is no confusion. Uppermost level of the palpable or visible breast tissue, maximum up to the inferior edge of the sternoclavicular joint. I just want to emphasize one more point here, that suppose you have a very obese patient with high body mass index, or patient who has large breast, and when you position the patients with arm up, sometimes breast tissue goes above sternoclavicular joint also. So here you need to individualize, and look at it. Don't just stop at inferior edge of the sternoclavicular joint thinking, okay, the guideline says this. So you need a little bit of individualization. Now let's talk about the caudal border or the lower border. For caudal border also there is little confusion. All guidelines agree that it should be most caudal slice of the breast tissue. ESTRO guideline also shows that in obese patients, sometimes CTV primary breast, the glandular tissue is positioned more ventrally. This is actually the fat. So you may not come till here. You may only include the glandular tissue. This will help in reducing the cardiac doses a bit. It is difficult to identify this. I have tried it myself several times. Sometimes I am able to identify, sometimes I am not able to identify. I also want to emphasize that in case I agree that the most caudal CT slice showing the breast tissue is the lowermost border, but then suppose your patient has a tumor in lower quadrant of the breast, make sure that you give at least a centimeter margin below it, and especially so when it is a locally advanced breast cancer. I'm sure all of us have seen cases of locally advanced breast cancer with skin nodules extending over abdominal wall also. So if it is inferiorly located tumor, a very advanced tumor, then you can go down by 1 centimeter below the breast tissue also. Now, we talked about cranial border, then we talked about caudal border. Now, let's talk about dorsal border. So, ESTRO guideline says that the dorsal border for intact breast should be at the level of the pectoralis muscle or intercostal muscle when there is no breast tissue. I hope it is clear as is shown here. They do not ask us to include the pectoralis muscle. Now, I want to remind you here that when breast conservation surgery is done, then surgeons also excise the tumor till the pectoral fascia. They also do not excise the pectoralis muscle because pectoral fascia is considered to be a tough barrier between the breast tissue and the pectoralis muscle. RTOG guideline, which is applicable for LABC or locally advanced breast cancers, also says that in case the tumor, if it is early breast cancer, then you may not include the pectoralis muscle. But if it is locally advanced breast cancer, then consider including the chest wall as well after a breast conserving surgery. So now let's talk about the fourth border, which is ventral border or the border towards skin. So ESTRO guideline says that it can be 5 millimeter under the skin, but it also says that if BCS is done for locally advanced breast cancer, for example, T4, B, C, or D cancers, then you may contour up to the skin and additional bolus may be applied. I generally I crop from skin by about 5 millimeter practically in all patients except for LABCs. I want to emphasize 2 points here. MS stands for my submission. My submission is that sometimes you have patients who have very thin atrophic breast. Then you may not crop it by 5 millimeter. You may crop by 3 or 4 millimeter below the skin. Another thing is that suppose you have a very superficially located tumor like this, then skin is also a part of the target. You may consider adding a small patch of bolus around the scar. You may not cover the entire breast with bolus, but you may add a small patch of bolus and selectively take your volumes in the tumor bed area near the skin. Now let's talk about the two controversial borders. So far, there was little controversy in BCS contouring for the CTV primary. Let's talk about the controversy, the medial border. So the medial border, it can be clinical reference or the wire that you have placed. Maximum is to the edge of ipsilateral sternum. This is the edge of the sternum. So this is the maximum limit for the medial border. ESTRO guideline says that CTV primary breast can be lateral to the memory branch of internal thoracic artery. So look at this volume. This is from the ESTRO guideline. This is the wire that they have placed, but they have not included that. In fact, there is approximately, my guess is about 2 to 3 centimeter gap. I think this is quite conservative in my opinion. Another border which is very controversial and difficult to delineate is the lateral border of the breast. It is very important to be careful about these borders. So lateral border depends on the breast ptosis. How much is the fall of the breast? Traditionally, we have been all taught about mid-axillary line of 1.5 to 2 centimeter beyond palpable breast tissue. I still sometimes tend to do that. ESTRO and Danish guideline says that you identify this lateral thoracic vessel and CTV primary will be medial to the lateral border will be medial to the lateral thoracic artery. While RTOG simply leaves it loose and says do not include latissimus dorsi muscle. After the after the ESTRO guidelines were published in 2015, there came a correction or addendum in the form of version 1.1 of the ESTRO contouring guidelines. Here they have said that sometimes the glandular breast tissue may be quite medial to the lateral thoracic vessel. So you may not even come up to the vessel. You may just include the glandular breast tissue. This is the ESTRO recommendation. I want to specify here that internal thoracic artery is a branch of subclavian artery which gives multiple memory branches, and sometimes surgeons find these perforator branches and clip them. You will find a lot of clips around these arteries, and lateral thoracic artery is again a branch of axillary artery, and it can be easily identified even in a non-contrast scan. Now, whether I agree with these medial and lateral border recommendations or whether I follow them in my practice, I would say I first believe in individualization. For example, suppose this is a pre-op scan of a patient with left-sided breast cancer, and you can see that the tumor is quite medially placed. So here I will not bother about the location of this internal thoracic artery and be medial to it. So you cannot just say that guideline says this, so I will do this. You have to individualize according to the location of the tumor. And I personally feel that typical breast CTV from ESTRO Atlas is far too conservative, especially in the medial and the lateral borders. And they have not respected the wires that they have put. They have not respected the anatomical landmarks that are visible on the CT scans. And I do not follow that in my practice. This is how generally we contour. The blue one is our CTV, and the red one is representing our PTV. And I tend to include some part of the pectoralis muscle also. And you see, I have put a wire here, lateral wire over the breast tissue, and we tend to go about a centimeter away from here. And medially also, we reach almost up to the sternum, lateral edge of the sternum. But it is the guidelines say that it is not required. Now, I have finished first part of my talk, which was about the CTV for intact breast. Now I'll come to the CTV of chest wall for post-mastectomy radiation therapy. Again, as I said earlier also, CT simulation is very important step, and we have to place radio-opaque wires on the MRM scar. And I also generally put wires around the landmark-based field borders. For example, my cranial border will be below the lower edge of the clavicle, or the lower border will be around 1.5 centimeter below the inframammary crease of the opposite breast, medial border till the lateral edge of sternum. So around all this, we put our wires, and then we acquire the CT scan. Generally, CTV guidelines are same, cranial, caudal, medial, lateral. They are same as for intact breast. The only difference is about the dorsal and ventral borders contouring when you're doing a chest wall contouring. So let's start with ventral. Ventral is towards the skin. So RTOG says that we have to go up to the skin. Estro says we can keep even in post-mastectomy radiation therapy 5 millimeter under the skin surface. Skin bolus of 3 to 5 millimeter thickness may be applied for a very thin chest wall. We have to remember that estro is only for early breast cancer. Danish guideline says keep it 5 millimeter under the skin surface except 3 centimeter cranial and caudal to the mastectomy scar where the volumes can be up to the skin with a skin bolus of 3 to 5 millimeter thickness. What I do in my practice is I go up to skin. For inflammatory breast cancer, I not only go up to the skin, I put bolus in all fractions also. We will come and discuss about the ventral border more in subsequent slides. Now let's also talk about the dorsal border. Dorsal border has always been much debated. There is a huge difference and it makes the position of the dorsal border of CTV chest wall makes a difference to the doses we are able to achieve for lung as well as heart. Now the RTOG guideline says that come to rib pleura interface, which means inner surface of the rib. This is the dorsal border recommended by RTOG guidelines. Danish guideline says pectoralis major or outer surface of the ribs. Estro says pectoral muscle or intercostal muscle where there is no pectoral muscle. So they say that unless Estro guideline says unless invasion was demonstrated, chest wall invasion was demonstrated in the form of T4A2C tumor, there is no reason to routinely include even major pectoral muscle or rib. So there is a lot of difference or a lot of controversy about the dorsal border. So RTOG is saying keep it at the inner surface of rib. Danish is saying outer surface of the rib. Estro is saying there is no need to include even the pectoralis muscle. Earlier, when these guidelines, contouring guidelines started appearing, these guidelines were mainly written by experts in the field of radiation oncology with a lot of experience. So they were based on eminence, experience, etc. But what we are seeing, the new guidelines which are coming now are mainly based on the patterns of failure after some of these patients have been treated with conformal or non-conformal radiation therapy techniques. So this is a very important publication which came in 2014. This publication from Vargo and Sushil Bariwal, it questioned the RTOG chest wall contouring guidelines for post-mastectomy radiation therapy. And the title says that, is it really evidence-based? So what they did was that they drew a cross-sectional anatomy of the chest wall. So this is the cross-sectional anatomy. This represents ribs and intercostal spaces. This is pectoralis minor. This is pectoralis major. This is subcutaneous tissue and this is skin. So they mapped 278 chest wall recurrences from 5 retrospective series and they mapped where was the location of these chest wall recurrences. So for example, in the Harvard series, but 100% recurrences in 17 patients were there in the subcutaneous space. In MD Anderson series, 60 patients, 93% patients had recurrence in the subcutaneous space. So they found by analyzing these 5 retrospective series that the most common site of chest wall recurrence was skin and subcutaneous tissue anterior to pectoralis muscle. This is pectoralis muscle. 72 to 100% of the patients. And the second most common site was pectoralis muscle. And none of the recurrences occurred in the rib or the intercostal muscles. They in their retrospective analysis they have also said that this pattern of failure may not hold true for inflammatory breast cancer or where patients have deep chest wall recurrences may occur in the setting of large ulceration, multiple prior recurrences or re-radiation. This is in the de novo early breast cancer kind of a situation or moderately advanced kind of a breast cancer situation. And they recommended that RTOG guidelines probably need a revision and need to bring the CTV chest wall CTV chest wall dorsal border to anterior or outer rib surface based on the patterns of failure in the literature. So this paper by Vargo et al. The publication came in 2015. And then in 2016 came a very interesting paper from South Korea by Chang et al., where they also looked at their patients who had recurrences and they did a 3D analysis of patterns of recurrences with respect to the estro contouring guidelines. So it was a retrospective study from Korea, including close to 5,000 patients treated from 2000 to 2012 with or without radiation therapy. Both BCS and MRM patients were included. More than 90% patients received adequate systemic treatment. Patients who had stage 4 disease or N3 disease were excluded. So majority patients had early disease. The radiation doses were pretty standard, including the boost which was given, and comprehensive lymph node radiation was done for all N2 disease. By this, I mean that comprehensive or standard chemo radiation therapy was done for all these patients. So they classified their loco-regional recurrences into two groups: outside RTOG volume, which is a big volume, and second was outside estro but within RTOG volumes. They were trying to validate whether the estro guidelines are applicable to their breast cancer patients or not. So they had a cohort of, out of those 5,000, close to 5,000 women, they had 139 women who developed 235 recurrences. So the total recurrence rate was quite low, 4.3%, of which local recurrences were 92, which formed 1.7%, and 63 were isolated local recurrences, and 2.65% were regional recurrences. Of all the 92 local recurrences, 70% in the BCS and around 58% in the MRM occurred near the original tumor bed. When they classified these recurrences outside RTOG or outside estro, they found that 14% patients had recurrences outside RTOG volume, which is the big volume. 14% patients had recurrences outside estro and inside RTOG CTV. This was an overall 14%. For BCS patient, this rate was 3.6%, meaning that majority of these recurrences outside estro and inside RTOG were seen in the patients who were getting post-mastectomy radiation therapy. The factors on multivariate analysis which were associated with high rate of loco-regional recurrences outside estro and inside RTOG volumes were young patients, advanced disease, and mastectomy patients. When they looked at the location of these lymph nodes, all patients who had local recurrences at pectoral muscle, intercostal muscles, and rib, they also had thin chest wall or slender physique. They said that Korean population has more slender physique. So the thin chest wall probably allowed tumor to easily extend through the muscle fascia. My two messages by going through this study with all of you is that I want to emphasize that majority recurrences were occurring close to the previous original site of the tumor. So while we are doing contouring for BCS or MRM, we need to pay attention to the location of the tumor, and because majority recurrences occur within that area, majority local recurrences. The second point is that if you have a very thin built patient or a patient with a very thin chest wall, maybe less than 1 centimeter, we have to be more liberal, and we may not stay only on the outer surface of the rib. We might come on the inner surface of the rib when we are doing post mastectomy radiation therapy contouring. So this group by Chang et al., what they did was they again took the cross section which was created by Virgo et al. These are the patterns of failure which Virgo had demonstrated: 70 to 100% in the pre-pectoral area, about 20% in the pectoralis major. They said that 68% of their patients had recurrences. Most common site was in the skin and subcutaneous tissue, but 15% patients had recurrences in the pectoralis muscle, and 18% patients also had recurrences in the rib and the chest wall, questioning whether the argument made by Vargo et al. Is valid or not. Going forward, next year, the same group by Chang et al. In 2017 came out with another multi-institutional prospective study on the patterns of failure for breast cancer patients. So in this, they included patients who were treated between 2006 to 2014, and they looked at all patients who had local regional recurrences. So this time they had a chunk of 234 patients with 337 recurrences, and again they mapped recurrences on a reference CT scan, and now they classified it into three categories: inside estro, outside estro and inside RTOG, and outside RTOG volumes. So they found that 3 patients, which means 3.2% patients, had recurrences outside RTOG volume, which was located at the anterior surface of the midline skin or soft tissue of the conserved breast. These three patients had tumor. All the three had tumor in the inner location. That is why probably the recurrence was occurring in the soft tissue around the midline. Two had non-ductal histology, two had positive cut margin, and all three were BCS patients. I again want to emphasize that when we are doing contouring, we should not be doing a standard contouring for our patients. We need to individualize and adapt according to the location and size and T stage of the tumor, as well as lymphovascular invasion, etc. While we are doing contouring, because as you can see here, that all these patients who had recurrences in the midline of the skin, they had tumor in the inner location. When they looked at the local recurrences outside estro and inside RTOG, 9.6% patients were there who had this kind of a recurrence, and all were at the pectoralis muscle. And the pectoralis muscle recurrence was more common in MRM than in BCS, 28% versus 3%, and the p-value was significant. So then, following this, Vargo et al. Came with another publication. This publication it says that lack of consensus of international contouring guidelines for the dorsal border of the chest wall, CTV. What is the impact in the era of modern radiation therapy, with some details about the patterns of recurrences. So this time, Vargo et al. Came out with their prospective data. Earlier, they came out with retrospective data from 5 institutions. Now, this is their own database from 2005 to 2017. They reviewed the location of recurrences on preoperative imaging and postoperative histopathology. They found 69 patients were evaluable and 17 were found to be suitable. They found that median time to local recurrence was around 2.25 years. 64.7% recurrences were in the skin and subcutaneous tissue anterior to pectoralis muscle. 23.5% were tissue anterior to and between the pectoralis muscle. This is the prospective database. And 11.28% patients had between pectoralis major and minor also, while none of the recurrences occurred deep to the pectoralis minor. And then they said that probably this is the time that now we have mature data of patterns of failure. So they said that probably we need to find a middle path between ESTRO and RTOG guidelines. So for example, follow this C picture with me. Here the red color volume represents the RTOG dorsal border and the volume, while the yellow represents the estro recommended volume where the pectoralis muscle is not included, while the green is the volume that they have recommended, which is akin to the Danish recommendation, which means we stay on the outer surface of the rib, but we include the pectoralis muscle. So I think this gives us a lot of clarity. This is how we generally contour in my hospital along with my colleagues. We stay on the outer surface of the ribs, but we include the pectoralis muscle. Ventrally, we go up to the skin. We add bolus, sometimes for all fractions, sometimes for at least 2/3 of the treatment. Our volumes are a bit tapering on medial and lateral edges, which also helps us in reducing the dose um, to the lung as well as the heart. For example, here we are not making it a square box like this, and we've had no regrets about following this. We generally do tangential IMRT with gel bolus is added. This is 95% dose wash. This is our 50% dose wash, which is similar to the tangential fields that we used to earlier do. Sometimes we also do scar boost. The scar boost is considered because majority of the recurrences occur in the skin and subcutaneous tissue. So we tend to give scar boost with 2.5 to 3 centimeter craniocaudal margin to the MRM scar, generally with 6 MeV electrons with bolus 4 to 5 gray in 2 fractions. I would like to cover a bit about inflammatory breast cancers. All of us have to know what is the correct definition of inflammatory breast cancer. There are several definitions. If the breast surface, more than 25% of the breast surface is involved by pudy orange, or there is presence of dermal lymphatic invasion in the histopathology, which can only be identified either after the MRM is done, so that the pathologist gets the full specimen, or if full thickness skin biopsy is done. A surgeon has to make an incision into the skin and take out the full chunk of the skin. Only then the dermal lymphatic invasion can be reported by a pathologist. We have to remember that in case there is an inflammatory breast cancer, these patients have a much higher chance of local recurrences like skin and soft tissue, as well as deep chest wall recurrences. So it is mandatory to include the skin in the target volume, use bolus for all fractions. We stay on the inner surface of the ribs, we give scar boost, and we may or may not consider even dose escalation for inflammatory breast cancer. I would like to just show you one case for discussion here. This was operated by a dear friend. She's a breast surgeon. It was her own relative. They found that there was a preoperative PET scan was showing that there was a diffuse central mass, and this lesion was infiltrating up to the pectoralis muscle. Intraoperatively, they found that there was a separate subpectoral nodule along the third rib. So they excised pectoralis muscle and the surgical flips were applied. So this is how the volume looked to us when the patient came to us. So in this case, we have to individualize. Individualization is the key. So here you have to come to the inner surface of the rib in your CTV. We in fact gave a electron boost with CT-based planning after doing the chest wall radiation to this patient. So basically there are no shortcuts. If you ask a surgeon, he will say that for me, MRM of every patient will have 90% basic steps, but 10% different steps as per the anatomy, location of the tumor, etc. And so do we have to do. We have to follow the guidelines, we have to know the guidelines. 90% of the things would be similar for all patients, but 10% adaptation is required. Here, I also want to add another talk a bit about another controversy, which is about the use of bolus in post-mastectomy radiation therapy. So this paper came in 2021 in Red Journal. This is a British Columbia database. They included patients who underwent PMRT, post-mastectomy radiation therapy without reconstruction, and they looked at the cumulative incidence of local recurrences, local regional recurrences, and breast cancer mortality in patients who were treated with bolus versus no bolus. 98% patients had systemic therapy also. They found that the 10-year rate of local recurrence was 1.9% in the bolus group and 0.09% in the no bolus group, and it was non-significant difference. So this is the study, and then there are several other studies which have actually questioned the use of bolus, because the use of bolus does increase skin dose, but it comes at the increased toxicity or dermatitis also. So it is a matter of debate. Again, I would say it is a matter of individualization. Suppose you have a patient who has T2 disease, T3 disease, N1. Maybe you may not put bolus at all or for all fractions. Because now, especially if you're doing VMAT or IMRT, then your skin dose increases. But make sure that if you're doing IMRT, you're not using bolus. At least a skin flash tool should be applied by the physicist, where they take fluents manually into the air, so that even if the patient is breathing, the skin and the subcutaneous tissue does not get underdosed. Don't get very overconfident in removing the bolus, because the most common pattern of failure is still skin and subcutaneous tissue anterior to the pectoralis muscle, and it should be treated adequately. So this was the end of the second part of my presentation, which was about CTV chest wall. Now I'll come to the third part, which is about tumor bed boost volume. So I think accurate tumor bed localization is very important, which is Asso recommends that tumor bed boost should be given to all patients who are less than 50 years of age, and those above 50 years of age with high risk features such as high grade tumors or positive margins. And uh, this is a phase 2 of CTV breast planning in an intact breast patient. And we also need to adequately localize the tumor bed for partial breast radiation also. Earlier, it was very simple. The surgeon would place a scar, you know, at the center of the tumor, and then when you would take an ultrasound or CT scan, you could see the postoperative seroma cavity, and the clips were placed intraoperatively. But now the challenge is that we are in the era of oncoplastic surgery, and now it is gradually becoming a standard of care. The advantage of oncoplastic surgery is that it allows for BCS for large tumors or tumors in challenging location to be resected while we are maintaining the balance of cosmesis and oncological resection. The caveat is that although oncoplasty has increased the ability of surgical oncologists to perform BCS, it has increased the challenges for adjuvant radiation therapy in terms of tumor bed localization. We were all used to seeing this kind of planning scans with a good seroma, nice clips, etc. But now the scans which we get look sometimes like this, and we all took little time to adapt to this kind of CT scans. Now, there are several issues while we try to localize the tumor bed boost for boost after oncoplastic surgery. The incision is not placed over over the tumor. It is a cosmetically planned incision. The lumpectomy cavity is closed from bottom to top, so the tissue is approximated at every level. So there is no seroma, there is no seroma cavity. The breast tissue flaps are rotated from other areas of the breast into the lumpectomy cavity to fill the defect. So the true tumor bed may be actually very far away from the original lumpectomy cavity. There is a lot of variability in the clip placement process amongst various surgeons, and there is no consensus. So it all leads to a huge potential for geographical miss, which might lead to increase in the local recurrences, which might also impact the overall survival. When we are very uncertain as a radiation oncologist in tumor bed identification, we tend to irradiate larger volume, which means more dose to the breast, more dose to the lung, more dose to the heart, poor cosmesis, higher incidence of fat necrosis. So I think what is required is we have little choice. Oncoplastic surgery is here to stay. So we need to learn how to deal with tumor bed localization after oncoplasty surgery. So there can be three case type of surgical case scenarios. One is open cavity surgery, where a surgeon does a lumpectomy and closes only the superficial part of the cavity around the skin and leaves the cavity open so that the seroma fills. This is called as open cavity surgery, where we can see a nice seroma. The other second part is closed cavity surgery, where the scar may be placed or the incision may be placed right over the tumor. After they dig deep to the up to the pectoralis fascia, remove the tumor with margins, but then they do a full thickness closure by suturing deep as well as superficial layers of the surrounding breast tissue. So the seroma does not form, does not develop. Target definition is difficult. The third can be oncoplastic surgery. In oncoplastic surgery, they not only do closure in from deep to superficial layer, they also move the pillars of the breast. So there is a large tissue movement, and this is the most challenging, scenario for us. There's something called as cavity visualization score. So let's start with cavity CVS5. CVS5 is when you can see the cavity very well. This is an open cavity surgery. And when it is closed cavity surgery, then generally we get this kind of appearance of cavity or no cavity. So in 2020, there is a very interesting paper which talked about the effectiveness of intraoperative clip placement in improving the radiation therapy boost targeting after oncoplastic surgery. So this very small study from Boston, only 39 patients, all patients had level 2 oncoplastic surgery. 6 mm titanium clips, maximum 6 in number, were placed to mark the walls of the tumor bed. They recommended putting these clips after excision of the tumor and before starting reconstruction or before moving the breast tissue. So the tissue rearrangement was done only after the clip placement, and 3 radiation oncologists were given the planning CT scans to independently contour the tumor bed. There were all kind of oncoplastic surgeries, superior middle, vise type pattern, hemi bat wing, double donut, etc., etc. So this is a surgical, picture of how the excision was done and the final cosmesis. And the red ones are the clips. So the clips were placed before mobilizing the tumor. And they found that the inter-observer variability in the delineation of the tumor bed was significantly reduced in patients with surgical clips. And post hoc analysis shows that 4 clips were actually sufficient to reduce the inter-observer variability. So I think we all need to talk to our surgeons and we all need to emphasize and tell them that you want to do oncoplastic surgery, we have no problem. Go ahead. I'm sure the patient benefits, and that's why you're doing all this. We'll be very happy if we get to see the patients preoperatively. And even if we do not get to see the patients preoperatively, make sure that you apply the surgical clips on all the walls of the tumor bed before mobilizing the breast tissue. There's something more which is coming up in this field of tumor bed localization. There are multiple studies which are talking that after the excision is done, the surgeon puts a opaque hydrogel in the cavity. it just gets smeared along all the walls of the cavity, which also helps in localization of the tumor bed for the purpose of boost. And this is a work in progress. I'm sure we will have an answer very soon. Till then, I want to identify that if you have to deal with a closed cavity surgery, then there are certain basic steps which have to be followed while doing the tumor bed delineation. First is certainly you have to do a good quality CT scan and identify the target relevant surgical clips. You have to understand that there are two kinds of clips which are generally placed: intraparenchymal clips and clips on the thoracic walls. It is the intraparenchymal clips which must be included in the target. Ideally, the intraoperative notes have to mention which are the relevant and which are the irrelevant clips. Then, the way we have scar over the breast, we also have a surgical scar inside the breast tissue also. So, we have to delineate the surgical scar inside the breast, the entire scar. And if this surgical bed scar is not visible, then we have to include the space between the skin scar and the clips on the thoracic wall as a virtual scar. If there are no clips, and the scar is also not visible, then the tumor bed cannot be delineated. So this is how the whole scar would appear. So the first step was CT simulation, then was identification of the relevant clips, and then you have to draw the breast scar. After that, you have to draw pre-operative tumor volume, which is called as imaging related tumor volume or target volume. You have to look at the pre-operative imaging like mammogram, MRI, ultrasound, CT, PET scan, etc. And then you have to take relative distance between the center of the tumor from the with respect to skin and chest wall, and project it after applying the correct magnification or demagnification factor on the planning CT scan. For example, if you this is a picture from the Eastro Atlas, they say that if the tumor was located here and you find that this is 85 millimeter, then you know that this tumor was at 0.4% depth from the chest wall. So here you measure this distance, and at about a quarter of distance from the chest wall, you make a projection of where the anticipated tumor was. Earlier, I was working in one very small center, and we had a very good relationship with our breast surgeon. So we used to take a lot of pre-operative scans for our patients, where we did not have to apply all this magnification and demagnification factor. We had a pre-op CT scan stored in our TPS planning system. So by the time patient would come, we would already know where the tumor was located. So planning CT, clip marking, internal scar, preoperative GTV, and then you have to make what is called as ETB or estimated tumor bed, which is a combination of surgical clips, whole scar, and image-based tumor volume. You mark all these things together. This is called as estimated tumor bed. And from this estimated tumor bed, you have to give a safety margin to create the CTV. Now, the CTV margin which is recommended is 20 millimeter minus the surgical margin. What does that mean? Suppose I want to give in the histopathology specimen, the histopathology report says that the anterior margin of the tumor from the breast tissue was 10 millimeter. Then I will add only 20 millimeter minus 10, which is 10 millimeter or 1 centimeter margin around the estimated tumor bed in the anterior direction. I hope I'm clear. Read this paper and then you will understand that you have to minus the surgical margin, which is already taken by the surgeon, as mentioned in the histopathology report, from the 20 millimeter margin. And then you have to give an appropriate PTV to arrive at the tumor bed boost. This is how the internal scar looks. You can see the surgical clips here. This is one of our patients. And then finally, this is our CTV. You can see that we've covered the clips, we've given the margin of around 2 centimeter, and we've given the margin to the internal scar also. So this brings me to the end of the third part of the presentation, which was about tumor bed volume localization. I'll be briefly talking about contouring after implant-based reconstruction, because implant-based reconstruction after MRM is becoming quite a norm and all of us have to understand about it. I must admit here that I personally do not have experience of treating the implant, chest wall after implant-based reconstruction. I am only presenting what I have understood from the guidelines. So following mastectomy, there can be two kinds of reconstructions which are possible. One is a allogenic reconstruction or the other is a autologous. Autologous means using the own body tissue like tram flap, LD flap, other flaps, etc. And alloplastic can be a single stage implant or first putting a tissue expander followed by an implant. So this is the implant. These are all autologous reconstructions. This is LD flap and this is tram flap. So I think if I'm correct, 2021 came these guidelines, ESTRO guidelines, which talk about delineation of CTV for post-mastectomy radiation therapy in setting of implant-based reconstruction, both implant as well as autologous reconstruction. So first of all, recommendations for target volume delineation for chest wall. It says that you have to do a detailed clinical examination and draw diagrams or click pictures to understand what is the surgical procedure which has been done, where all the scars are. Then you have to read in detail about the surgical and pathological reports. Then you have to mark with wires the scar and the palpable, visible, anatomical, and surgical effects. For example, borders of surgical resection of subcutaneous breast and fatty tissue. We have to remember that in this case, skin is not a part of clinical target volume, except in patients with locally advanced breast cancer, B, C, or D breast cancer, CTV, T4, B, C, or D. The CTV is essentially remaining glandular breast tissue. There is some amount of uncertainty which always remains in defining this residual glandular breast tissue after MRM and implant-based reconstruction. But majority studies have shown that the location of the residual glandular tissue is variable and it depends on the surgical procedure performed with or without, whether the surgery has been performed with or without skin and nipple sparing or not. But in most patients, this residual glandular tissue is found in the axillary tail, and in about quarter of the patient, it is seen in the upper inner quadrant also. So upper outer and upper inner. So the borders of when the surgeon does this kind of MRM, they have to put an implant in place. So they do not remove the entire skin of the chest wall. There are borders of the residual skin which we have to identify along with our surgeon when we are doing the planning CT scan. And the CT scan should also be carefully reviewed for residual breast tissue, which is not evident on physical examination. So basically, this contouring is a combination of your clinical examination findings, your CT findings, inputs from the surgeons, and some amount of imagination. Now, we have to understand what are the surgical procedures which are done for implant-based reconstruction. The implant may be positioned either pre or post, matlab anterior or posterior to the pectoralis major muscle. For example, look at the figure A. So this is rib and intercostal muscles. This blue one is the implant and the orange one anteriorly is the pectoralis muscle. So the implant is retropectoral. Implant is posterior to pectoralis major muscle. Now look at figure C. In figure C, this is pectoral muscle. This blue one is implant, and then there is a skin and subcutaneous tissue. So this is pre-pectoral. Now let's come to figure B. In figure B, the implant is retropectoral. So this is pectoralis major muscle. But probably the pectoralis major muscle was not enough to cover the entire implant. So there inferiorly, the surgeon has placed some synthetic surgical mesh kind of a tissue to cover the implant, while superiorly the pectoralis muscle is covering the implant. So whenever we have to do CTV contouring in a implant setting, we have to understand what has been done, A, B, or C, you know. And as I mentioned earlier, also the CTV is residual subcutaneous glandular breast tissue and subcutaneous lymphatics, and skin is not a target. So the most common site of recurrence after mastectomy has been shown to be at the level of skin and subcutaneous tissue, which is around 70 to 200%. And second most common site is within pectoralis muscle, especially near the site of the tumor. So in case we have to do contour CTV chest wall where the implant is positioned anterior to the major pectoral muscle, which is pre-pectoral, then we will only include the glandular tissue and the subcutaneous tissue. In case there is any muscle invasion, then only in that part we will include the pectoralis muscle. In case there is rib invasion, then we will selectively or focally include that particular area of the rib or intercostal muscle, and we are not supposed to include the entire pectoral muscle or the or the chest wall or the ribs. Now these are some of the pictures. So this is a CTV contouring for retropectoral implant. So here this is pectoralis muscle, which is just in the subcutaneous tissue. The green one represents the implant. So the CTV is the entire breast glandular tissue, which is subcutaneous tissue. Implant has to be excluded from the CTV chest wall. We may include a rim of rib or the chest wall muscle medial lateral in the medial lateral and caudal borders like this. In the medial part, where the pectoralis muscle is going to envelop the implant, and in the lateral part, and also in the inferior or the caudal part. I am not an expert in this, I am again admitting. Now, this is a CTV chest wall contouring after implant-based reconstruction for a patient who had a pre-pectoral implant. So this blue one is the chest wall. And so here, once there is a pre-pectoral implant, there are two parts of the CTV. Ventral part is between the skin and the implant, skin and the subcutaneous tissue, and any residual glandular tissue. And the dorsal part is between the implant and pectoralis muscle and the chest wall. This has to be included. The dorsal part has to be included only in presence of adverse factors like large tumor, locally advanced breast cancer, or invasion of the pectoralis muscle. Otherwise, we are supposed to include only the ventral part in our target volume. Why are we so concerned? Why are we so obsessed about this contouring? We are so worried and obsessed about this contouring because there are a number of complications which are reported after radiation therapy is done for after breast reconstruction with implant. There are studies which have talked about implant removal in about 20% of the patients after radiation therapy is done. And the complications are there because with radiation, there is a lot of fibrosis. This fibrosis forms a kind of a capsule, firm capsule around the implant, which can lead to the rupture or contracture of the implant, capsular contracture, gel leakage, implant rupture. All these are known conditions. I have myself seen one patient who had implant. She did not get radiation therapy. In spite of that, she was constantly running low-grade fever. The fever was just not going away. And when we got fed up, we were not able to identify any cause. We said, okay, let's also do one MRI of the breast. And then we found that there was some leakage. The capsule of the implant had ruptured. And for identifying all these things, we have to do MRI of these patients. There are two recommendations we have to follow to reduce the potential toxicities of radiation therapy after implant-based reconstruction. First is that bolus increases the toxicity. So bolus is not advised to be used after implant-based reconstruction, and we should not apply scar boost after mastectomy routinely in these patients who have implant-based reconstructions. So with this, I have covered the first four parts: breast contouring, chest wall contouring, tumor bed, as well as implant-based reconstruction. Now I'll move to the nodal contouring, which is also a very interesting part. First, I'll start with something which is very simple, that is internal memory node target delineation. Internal memory node artery is a branch of subclavian artery, and there is almost a consensus amongst all guidelines. This is a table which is showing all guidelines. The cranial edge has to start from first rib up to fifth rib. I will show you some of the pictures and explain how we do it. So practically, we do not do any prophylactic internal memory nodal radiation, not even for central quadrant tumor or inner quadrant tumor or for heavy axillary burden. At least we don't do it in our practice because we understand that internal memory nodal radiation, in spite of doing the most conformal techniques, have an impact on the cardiac and lung doses. We only do therapeutic IMN radiation, which means we do internal memory nodal RT only when the lymph nodes are present. There are 3 negative randomized trials and 1 meta-analysis against prophylactic IMC or RT, so we don't do it. So what we do is, when we look at the PET scan, which has helped us in locating these internal memory lymph nodes, we contour ipsilateral ribs from 1 to 5 on the PET scan to identify what is the level of lymph node location, level, whether it is a first intercostal space, second, third, etc. So we contour the ribs on the PET scan also to make sure that we know the correct level. Then on our CTV also, we contour ipsilateral ribs from its origin to insertion so that we know which intercostal spaces have to be treated. Then we contour internal memory vessels. We give 5 millimeter margin to internal memory vessels and include any site of any gross node. The medial border of the CTV will extend maximum up to the lateral edge of the sternum. Lateral edge is 5 millimeter beyond the blood vessels. Anterior border is 5 millimeter anterior to blood vessels. Posterior border, we give 0 millimeter margin towards lung parenchyma. And additionally, we give a PTV margin also. Sometimes the physicists, while planning, have to take care of the lung and heart doses, and they tend to, slightly underdose the internal memory nodal volumes. So we create one high risk volume also, the region which had gross lymph nodes, so that to avoid any underdosing in that particular area. So this is a picture which is showing that, this is the location of the internal memory lymph nodes, which is quite parasternal in location. So one has to contour it carefully, but this is not a difficult to do contouring. Let's talk about supraclavicular fossa lymph node contouring. This is quite controversial. I'll take long time to discuss this. First of all, we have to understand that supraclavicular fossa lymph node volume for breast cancer is quite different from that what we do in the head and neck cancers. In breast, it includes undissected axilla, which means area which is located to cranial to the axillary artery and vein. You will often hear surgeons saying that we have done infravenous dissection. The surgeons, when they open the axilla, they only go up to axillary artery and vein. They do not go cranial to axillary artery and vein, because as soon as they go cranial to axillary artery and vein, they peel the sheath over the vein, then the incidence of lymphedema increases quite a bit after surgery. So they generally do infra artery and vein dissection. So the area which is cranial to that has to be included. Supraclavicular fossa basically represents apex of the axilla. So level 3 axillary lymph nodes have to be included. Level 4A and 4B have to be included. Lateral supraclavicular lymph node or posterior triangle has to be included in case there is a heavy axillary lymph node or N3 disease, or there was a gross supraclavicular lymph node. For all sites, we have vessel-based contouring guidelines for lymph nodes. For breast cancer, nodal radiation also, we have a guideline which is based on the blood vessel-based delineation guideline, which comes by the name of PROCAB. So let's go through the guidelines for supraclavicular fossa contouring, which is quite variable. RTOG and Danish guideline says that the cranial border of SCF field has to be at the edge of the caudal edge of the cricoid cartilage, while ESTRO says 5 millimeter cranial to the subclavian vein, and PROCAB says cranial edge of the subclavian artery arch. This is subclavian artery arch. So here it asks you to stop it. So here it says stop it. So I find that this is quite low. I generally go for SCF up to the lower border of cricoid cartilage. The caudal border is also quite variable. RTOG says very simple thing. It says junction of brachiocephalic or axillary vein, or go up to the caudal edge of the clavicle, which is what we follow in our practice. The Danish guideline says sternoclavicular joint. ESTRO says 5 millimeter caudal to the subclavian vein. So this is subclavian vein. So it says just 5 millimeter below this. Now, PROCAB says 5 millimeter below the caudal edge of the junction of subclavian vein and IJV. Again, 5 millimeter below this. I generally take it up to the lower border of the medial head of the clavicle. I make sure that to cover the junction of the first rib and the clavicle well, because this is where the subclavian vein gives rise to the internal memory artery also. For the medial border of the SCF, there is little confusion. All guidelines say that you have to exclude thyroid and trachea. Some say include carotid, some say include IJV. Not a big deal. I will say you have to include the vessels. You don't have to go beyond the vessels, but exclude thyroid and trachea. The lateral border is most controversial. So RTOG says cranially and caudally it gives two lateral borders. Cranially it has to be scalene muscles. So these are scalene muscles. It says that cover the entire scalene muscles. And so the lateral border will be somewhere actually till here. This is sternocleidomastoid muscle, the cyan one. Caudally it says junction of the first rib and the clavicle. DBCG, Danish guideline says go up to the medial edge of pectoralis minor and clavicle. Istro says to connect the lateral margin of axillary level 3 lymph nodes and include the scalene muscles. So it is, I will come to this point once again about the lateral border. For ventral, again, there is no confusion. Everyone says that we have to stay at the dorsal surface of sternocleidomastoid muscle. For dorsal border also, there is no confusion. All guidelines say that you have to remain at the anterior aspect of scalene muscle. And as you go down, you have to stay at the level of the lung. So this is DBCG guidelines. So this is sternocleidomastoid. These are scalene muscles. So it is medially, it is including the blood vessels, excluding the thyroid gland. Then this entire space is taken. See, if we were doing the contouring for head and neck cancer, we would say that, the lateral edge of the sternocleidomastoid is the most important landmark. But here the landmark is scalene muscles. So see, they have covered this periclavicular lymph nodes. This whole area has been covered. This is pectoralis minor muscle. So here again, they have included this entire area. My SCF contouring is quite liberal. I admit that. So we do not include the gland. This is actually PTV. Blood vessels are included. Some of it is coming on the scalene muscles. And we try to respect the pectoralis minor muscle also. We include the lateral part, go up to the medial edge of the pectoralis minor muscle also. Cranially, we go up to the caudal edge of the cricoid cartilage. Caudally, we come up to the lowermost level of the clavicle bone. So these are some of our contours. Now, as we were talking about patterns of failure for chest wall, similarly, there are very interesting papers, 3 or 4 papers. I'm talking only about one paper, which is about, patterns of supraclavicular lymph nodes at presentation or at recurrence and its impact on the delineation of SCF target volume. So in this paper, they have mapped the location of the gross supraclavicular lymph node in patients with breast cancer. 62 patients, 161 supraclavicular lymph nodes at diagnosis or at recurrence, they were included. And the location of the supraclavicular lymph nodes were mapped on CT, MR, PET scan, and then they were transferred to one reference scan. And all the lymph nodes were plotted on the left side with a circle of diameter of 5 millimeter. So when they looked at the distribution of supraclavicular lymph nodes at diagnosis, they found that 40% lymph nodes were actually outside the RTOG volume also. Where were these lymph nodes located? These were located at the level of thyroid or cricoid cartilage, which is cranial to RTOG boundary, or in the posterolateral part, or in the posterior triangle, or lateral lower supraclavicular fossa below the level of the transverse cervical vessels and lateral to the scalene muscles, or between anterior and middle scalene muscles. There were no recurrences medial to the medial border of internal carotid artery. So there is no confusion about cranial border. There is some confusion about lateral, cranial, and caudal borders with respect to the RTOG recommendation. So I'm going to take you through the CT scan pictures from this article. I'm going to show you multiple pictures. So this is axillary vein, probably axillary artery or vein. This is clavicle. And here they have mapped these lymph nodes. They have plotted these lymph nodes as 5 millimeter circle. I'm going to go from below up. So follow me. So look at the location of the lymph nodes. All the lymph nodes are, here within the volume periclavicular location. But now look at it here. These are scalene muscles. So look at the lymph nodes. They are present so much in the posterior triangle beyond the scalene muscle also. I'm further going down. Look at the location of some of these lymph nodes. These are scalene muscles. Look at this. Look at this cluster. I'm sorry, I'm going up. Look at this cluster. This is sternocleidomastoid muscle, quite lateral and posterior. This same study also looked at the distribution of lymph nodes at recurrence and again found that 34% of the lymph nodes were located outside the RTOG volume. And again, the location of the lymph nodes was same. Lateral low supraclavicular posterior triangle at the level of the thyroid cartilage. There were no recurrences medial to the medial border of clavicle. Again, I'm showing you these nodal recurrences marked in circles. These papers gave me, I think, a wealth of information because eventually whatever we do has to be, I think, more based on the patterns of failure rather than only on the anatomical landmarks or on the guidelines. So I think we need more generous coverage of supraclavicular CTV laterally till the lateral most extent of the scalene musculature in all patients, more generous coverage of the posterior triangles in patients with indications for regional nodal radiation. Cranial border has to be above cricoid cartilage, especially in patients who have supraclavicular lymph nodes at presentation. This is the PET scan of one of our patients who had, this was her recurrence. This is at recurrence, post radiation. Look at the location of this lymph node. Who would imagine lymph node at this location? So the point that I'm trying to emphasize and re-emphasize here is that do not contour supraclavicular fossa in breast cancer patients the way we do it in the breast cancer in the head neck patients. It requires a different mindset. In the interest of time, I'm going to skip the axillary nodal contouring guidelines. I think all of you can go through this. I will quickly wind up by talking a bit about OAR contouring because OAR contouring is also very, very essential. All these OARs have to be contoured. Hard substructure contouring is actually optional. Left ventricle, coronary artery, especially LAD, lungs, ipsilateral, contralateral, esophagus, larynx, contralateral breast, skin. Any skin folds have to be contoured. Brachial plexus is optional. Spinal cord and humerus. Sometimes we tend to, ignore the importance of esophageal dose in patients who are getting supraclavicular fossa radiation. We tend to contour the entire esophagus from cricopharynx to the GE junction, and the mean dose of esophagus comes 1 or 2 gray or 4 gray, and we feel very happy. But when our patients come in the OPD, they have esophagitis or painful swallowing. What is recommended according to this paper, and which we also follow in our practice, is that you have to contour one upper esophagus, which can be maybe up to from the cricopharynx up to the carina, and try to keep the mean dose of this upper esophagus to less than 14 to 15 gray when you're prescribing 40 gray in 15 fraction hypofractionated RT. And also look at that volume receiving 25 gray should be less than 20%, and volume receiving 35 gray should be less than 0.3 cc to avoid esophagitis, severe esophagitis in your patients. Heart is a known OAR. There are certain known facts that heart doses are very important in breast and lymphoma patients, especially because they are going to be long-term survivors. It is more important as compared to patients of lung cancer and esophagus patients. And late cardiac morbidity is a known complication of radiation, and heart is both a serial and a parallel structure. This question is often asked in exams whether heart is a serial structure or a parallel structure. So the musculature of the heart is a parallel structure while coronary arteries are a serial structure. And doses to substructures of the heart, left ventricle, coronary arteries, etc., is very, very important. The fact that we do not know is what is the threshold below which radiation dose to the heart is safe. We do not know what exactly is the ideal or the safest dose to the heart, 1 gray, 2 gray, 2.5 gray. So since we do not know, our goal should be to achieve as low as achievable. We try to achieve ALARA doses for heart, and we may use any of the techniques like APBI, breath holding, proton, anything we may do. This is the first cardiac atlas which was proposed by Mary Fang. She's very popular. Cardiac atlas, which was cardiac CT atlas, which was jointly developed by cardiologists, cardiac oncologists, and radiation oncologists. And they have said that superiorly heart starts just inferior to the left pulmonary artery, and inferiorly it blends with the diaphragm. And since cardiac vessels run in the fatty tissue within the pericardium, they should be included in the contours even if there is no heart muscle visible in that area, and exclude superior vena cava. So look at this. Just below the pulmonary artery, the cardiac contouring starts, and IVC has to be excluded as far as possible. If you can identify in patients with lymphoma, it is important to contour the valves also. Once you go through this paper, I'm sure you will be able to do this. LED contouring is not simple. There are several challenges. LED may not entirely be visible. There is difficulty in visualization. Even if you give the contrast, you will not see the LED because then you need a cardiac kind of a CT scan. Then there are respiratory and cardiac motions, which because of they cause blurring due to motion. So there is often a discussion, should we add some PRV to the LED? It's very small. LED can have 1, 2, 3 diagonal branches, which become more difficult to identify because they are still smaller in caliber, and there is a lot of inter-variable observer variability. And then came this this Taiwanese paper which says that don't contour LAD, contour LADR, which is LAD region. So the entire region which possibly can have LAD. This is a CT angiogram which is showing the diagonal branches. It is so difficult to identify these branches on a non-contrast scan and even in a contrast scan. So this very interesting Taiwanese paper says that contour the entire LAD region over here also towards apex of the heart. Please go through these guidelines. It is very difficult to explain it in a webinar. You have to go through this paper and table to understand how to contour the LAD region. We again do not know what are the safe doses to the LAD. So we have to control both max and mean dose of LAD by using the principle of ALARA. When it comes to contouring lungs, it is very important to contour ipsilateral and contralateral lung as a separate structure, auto segment, and then manually correct. Remember, both V5 and V40. Low doses as well as high doses are very important. Ipsilateral lung doses are important to prevent pneumonitis and second malignancy, and contralateral lung doses are very important to prevent radiation-induced second malignancy. Remember that contralateral normal breast is also an OAR because we want to avoid the risk of radiation-induced second malignancies. I generally tend to avoid VMAT plans for all our breast cancer patients unless it is a very complex volume where you have to treat the chest wall or the breast and the IMC and the SCF and the axilla, which is rare in these kind of days. But then you have to make sure that you are controlling even with VMAT the dose to the contralateral breast. I thank you all for your patient listening, at the fag end of the day. And I would like to acknowledge my colleagues who have also contributed and helped me prepare this presentation. Thank you, Dr. Adi, also.
It was a very elaborative and informative presentation, ma'am. Thanks for it. Uh, I would ask if Dr. Neha ma'am wants to say something about it.
Are there any questions?
Yes, there are.
You can take up the questions.
Okay, ma'am. Yeah. Uh, so the first question is, what do you do, ma'am, about inferior border when bilateral mastectomy has been done?
Good question. So, very difficult. But then, if you look at it carefully, even if bilateral mastectomy has been done, you will see some skin creases, which will give you an idea about where the inframammary crease of the breast was. So, first of all, by careful inspection, you'll be able to identify that area. The other thing which can be done is that I generally do in my practice is that when we were doing radiation therapy for chest wall in conventional era, then our field size for the chest wall would be generally 14 to 16 centimeter. So I make sure that still our cranial and caudal border, I mean the entire craniocaudal span of the field or the volume is around 14 to 16 centimeter. So you have to use some estimations.
Okay. What are the PTV margins in this trials? Is 5 mm enough for PTV?
So if you have a robust setup and if you're applying some kind of image guidance, I think 5 millimeter is a good PTV margin. And rest, as has always been said, PTV margins have to be individualized and calculated as per the department protocols and setups.
Yeah, ma'am. So the next question is, exactly in which cases do we contour breast plus chest wall, RTOG? And is it safe to say that we can contour our PTV's lateral border up till latissimus dorsi, not including it in most cases?
So I have understood the first part of the question. So let me answer that. The first part of the question is, when in BCS would you include the chest wall? My answer to that is extremely rarely that would happen, because generally breast conservation surgery would not be done for a very, very advanced breast cancer. Majority of these patients would have MRM. So such a situation would arise rarely in the practice. Sometimes patients become very adamant, or there is an over-aggressive surgeon who would say, okay, BCS is probably good enough for you. So if it is an LABC, inflammatory breast cancer, only in that kind of a situation, we will try to include the chest wall. But still, I would say that in 99% of the situations, we we will stay on the on the outer surface of the rib and would rarely go to the inner surface of the rib in a BCS setting.
Okay.
I did not understand about latissimus dorsi.
Uh, I guess she means to say, like, should we contour our CTV, the lateral border of our CTV, until the anterior border of latissimus dorsi, and not including it?
So
Like,
I
should
would
we
do
include?
that only in a laterally placed tumor. Suppose the tumor is positioned in an extremely lateral location, then I will consider, going so far lateral.
Okay. Can we omit part of scar away from the primary site if it is going to give more doses to lung or heart?
Yes, there is no in a MRM or in BCS, we do not have to chase the scars unless it was an inflammatory breast cancer, or the tumor was present at an extreme end, too far medial, too far lateral. Otherwise, we don't have to chase scars.
Do we need to use bolus scar in early stage cases other than T4?
I think you're not audible clearly.
Do we need to use scar bolus in early stage cases other than T4?
Not really. If you go by the recommendations, recently we had a small interaction with Dr. Sushil Periwal. Dr. Sushil Periwal is one of the authors in the studies which have talked about the patterns of failure in the chest wall. Sir also said that of late he has started using bolus selectively. In MRM cases, he is avoiding use of bolus in patients with early breast cancers. So probably I think gradually we will go away from the bolus. In my practice so far, I have not had the courage to remove the bolus in patients who've undergone MRM, but I think it is time to reconsider it.
Ma'am, in which cases do we require to give scar boost in MRM, and does it affect the lung and heart doses?
So first of all, generally the scar boost will not affect the lung and the heart doses, because scar boost is generally given using 4 or 6 MeV electrons along with bolus. So the dose will largely stay within the skin and the subcutaneous tissue. I generally tend to give a scar bolus in patients who have inflammatory breast cancer. I'm very clear. You have to have the clinical findings. You have to look at your scans. You have to read the histopathology report in detail. If you are seeing that there is extensive lymphovascular invasion present in the tumor area, or if the report is saying dermal lymphovascular invasion present, or skin infiltrated. So these are the patients where I would consider giving scar boost. The other situation where I sometimes get tempted to give scar boost are the patients where sometimes at the end of radiation, I do not see a good skin reaction. Then I worry about the skin doses and tend to add scar boost.
Madam, are we seeing the reactions nowadays? I don't think so. Like previously, we used to see those kind of skin reactions, but now I'm pretty not seeing these reactions nowadays. Are you still seeing the reactions on the chest wall?
Yes, we do see some skin reactions. I will not say that we do not see skin reactions at all. We see skin reactions, especially near the folds. Sometimes the patients have dog ears, folds, or sometimes near the axillary fold. Just 2 days back, I saw a patient, young lady. She's an Indian, she's of Indian origin. She came from Australia, and she had taken chest wall radiation. She chose mastectomy. She got very scared when she had breast cancer. And I could see a deep ulcer. It was a
Okay.
deep ulcer on the chest wall. I was quite pained to see that,
Mm.
the radiation.
So, in case if the boost has to be given, then what is the dose for this scar boost?
Dr. Neha, there
Is
is
there
no,
any literature on it? Yeah, I don't.
so there is only Danish group which recommends this kind of scar boost. So we generally tend to we give a scar boost with a margin of approximately 3 centimeter cranial and caudal to the scar. We do not always try to cover the scar from the medial to lateral end.
Okay.
Sometimes the scar is given, boost is given only to the central area or the area where the tumor was located, medial or lateral area, with a 1 centimeter bolus with 6 MeV electrons to a dose of 4 to 6 gray in 2 to 3 fractions.
Thank you.
So next question is, ma'am, in case of bilateral SCF node dissection, positive in baseline PET and biopsy proven, in a given case of ipsilateral breast cancer, should we treat contralateral breast also?
This is a very difficult question to answer. This is a clinical question. So the question is that suppose there is a left-sided breast cancer and there is a contralateral node. So if there is a contralateral supraclavicular lymph node, first of all, this lymph node has to be uh, proven by doing FNAC or biopsy. You have to also look at the PET scan. You also need a contralateral breast MRI to make sure that there is not a separate primary on the contralateral side also, which is being missed clinically or on mammogram. So you at least need a MRI of the breast on the contralateral side. Suppose everything is negative, PET scan is also not showing anything, MRI is also not showing anything, then I think it needs a discussion in the multidisciplinary tumor board. This patient would be at a very high risk of distant failure. But I think it merits a discussion. We had one such patient with young patient with triple negative breast cancer. We did treat contralateral supraclavicular fossa. Her disease remained in remission for about 2 years. And then she had brain metastasis and then lung metastasis. So overall, these patients have more distant metastasis. There's no correct answer.
Ma'am, how much dose constraints should we keep for skin folds if we contour it as a separate OR in pendulous breast?
It is not clearly known what is the dose constraint. I'll tell you what we do in our practice. First of all, wherever there are skin folds, we try to position the patient in such a manner that we are able to minimize those skin folds. But still, sometimes when there is an obese patient, you may not be able to avoid the folds in the neck or in the inframammary crease or in the lateral part of the breast. Sometimes they are just unavoidable. In that case, we contour them and we see if our CTV can be modified to avoid them. For example, suppose you have a lot of folds on the lateral side while your tumor is central or medial, then you might do slight corner cutting in the lateral area to avoid your target volume going into those folds. In addition, when our physicists are doing planning, we tell them to avoid hotspots in those areas. And we prophylactically, start giving skin care while doing review for these patients in terms of cleaning, hydration, positioning. For example, sometimes we tell the patient the pillow that we use in aircraft around our neck, we ask them to hold it around their arm so that the arm is not rubbing on the breast. So these kind of instructions you give, and you try to avoid skin reactions. You tell them to separate the skin folds in their normal daily routine.
I guess we don't have any more questions.
So
Okay,
I think
there's a question here. Do you aspirate seroma if it's there in CT simulation?
So if the seroma volume is quite large, then it is better to aspirate it. But then you should be prepared that some such patients will require multiple resimulations or adaptive RT.
right.
But if you do not aspirate, sometimes what happens is that then the whole seroma fibroses later on, and then it becomes a hard part. And that lady has to live with it all her life in that kind of a pain and misery. If it's a small seroma, then don't aspirate. It is very subjective.
I think there are no more questions now.
Yes.
So I think we come to the session and to the end of the session, and we thank you all, madam, for such a beautiful presentation and such an informative presentation. And we'd like to see more of your presentations in our future slides. Thank you
Thank
so
you,
much.
everyone. Thank you,
Thank you.
for staying till so late. Thank you so much.
Thank
So
you so much.
on the closing note, I would like to thank our chairperson, Dr. Neha ma'am, and our speaker, Dr. Vineeta ma'am. Thanks a lot, ma'am.
Thank you,
Thank you,
Dr.
Adit.